classification that I already went through, which is a transudate or an exudate. So basically a pleural effusion is no more than fluid in the pleural space. I gave you the types that you can have, like plasma, serous type, pus is an empyema, blood is a hemothorax, and lymph is a chylothorax. Another way, which I closed the patient already, but another way to diagnose this is looking at a glance, which is not accurate, okay? Looking at the thoracentesis values that I show you at glance. And if you see, even though it says 30, we interpret it as 3. When you look at the values and you look at the what number did I give you for the total protein here?
5.
Less than 2, right?
Yes.
Wasn't it less than 2?
Yes.
Okay. You look at that total protein value in the thoracentesis. And sometimes we don't even do the calculation, even though it's not the most accurate way to do it, okay? We look at the calculation and we say, if it's less than 3, you have a transudate. If it's more than 3, you have an exudate. Do you understand? But at the same time, at glance as well, so this is to prove you that is not accurate. At glance as well, you have another classification, which is LDH. If it's less than 200, you have a transudate. If it's more than 200, you have an exudate. And what value do we get? 350. So if you do it at glance like that, it's not as accurate as doing the actual calculation. Because you get an LDH with an exudate, and then you get the proteins with a transudate, and you're like, what is it? So do the calculation all the time, okay? Now, another way to translate, which I'm not going to ask you that way, listen. If your plasma value LDH is less than 2/3 of the fluid, you also have a transudate. So, in other words, I'm telling you exactly the same. LDH less than 200, transudate, more than 200, exudate. Okay?
200 or 2?
200.
Oh,
For protein, 2.
Ah.
For LDH, it's not. For LDH, it's less than 200.
But the example that you put last time, you used the number 3. Yes.
The
answer was
listen again. Don't get confused. No, don't tell her that. Don't tell her that.
What?
Don't tell her that. Clinically, what we use at glance is when we see the protein, the total protein in the thoracentesis, if it's less than 3, it's a transudate. If it's more than 3, it's an exudate. And we also look at the LDH value at glance. If it's less than 200, which is no more than 2/3 of the plasma LDH, is a transudate. If it's more than 200, if an exudate, right? But again, in this particular case, in this real patient, is contradicting. So that's the reason why you have to do always the calculation, okay? This is just telling you that a transudate is related to Starling law, meaning that the higher the pressure, the radius of the vessel is going to be altered, and therefore the fluid is going to leak to the outside, and leaks to the outside due to hydrostatic pressure increased or decreased oncotic pressure. And an exudate, remember that I told you, is due to no more than increased permeability or capillary permeability. That it was a word that you memorized all the time in the inflammatory cascade, right? So infection, inflammation, or obstruction of lymphatic drainage. This is the Leit's criteria that I explained to you. So basically you take the pleural fluid divided by 0. If it's more than 0.5, you have an exudate. You get the pleural fluid, LDH, divided by 0. And if you get more than 0.6, you have an exudate. Or if you take the pleural fluid LDH, is greater than 2/3 of the upper limit normal of the LDH is 0, which is no more than, it's a complicated sentence, but it's no more than the LDH in your pleural fluid is more than 200, you have an exudate. Okay? So you don't have to memorize the causes because you know that transudate is heart conditions or decreased proteins by malnutrition or by taking it out through the urine, right? And you don't have to memorize the exudates because exudates or inflammatory, infectious process, or cancer, okay? Or PEs, for example, as well. For example, PE, you have it here in an exudate, infection, tuberculosis, exudate, malignancy, exudate, and so forth, okay? So you don't have to memorize the causes. So basically what we do, as we say, is you have an x-ray that is telling you that the patient has moderate to large effusion. Please don't guide yourself through the reading. I have seen reports, large pleural effusion, and it's not. When you do an actual CAT scan and you look at that patient CAT scan, it's more pneumonia than fluid itself. We have a lot of residents and fellows reading radiology now more and more. So look at yourself. Try to learn, okay? And or if you win in doubt, well, actually in board examination, do a lateral decubitus, because again, the theory is that I don't want to tell that. No, give me a bottle. Oh, that one. This is the patient standing up. Okay, and if you have the diaphragms and the fluid is under the diaphragm, you actually need more than 300 mLs for the fluid to come outside of the diaphragm. That's how much fluid you need.
How much?
So sometimes 300. So you have a patient standing up and the patient could be full of fluid below the diaphragm and you don't see it. But if you put the patient in lateral decubitus, what happened to the fluid? So in your board examination, the first thing you have to do is put the patient in lateral decubitus and take an x-ray. We don't do that. What we do is an ultrasound, right? So you do a chest ultrasound to be able to see the amount of fluid that the patient has. And sometimes I have seen as well that this report is small, not to do with thoracentesis. You have to go, we have gone down and tell the radiologist you have to do thoracentesis in a patient. That fluid is not small.
Professor, so how do we differentiate from pneumonia in the x-ray and the pleural effusion?
No. Okay. Pleural effusion is no more than fluid leaking to the outside. And as you could see, pneumonia can also give it. So in an x-ray, how can you differentiate pneumonia from a pleural effusion? You really can, because if the fluid is above the pneumonia, you won't see the pneumonia unless you do a CAT scan. And you're able to see the infiltrate inside the CAT scan. I can open another, if you don't leave, I can open another CAT scan and show you the difference. Okay?
Professor, and the fluid will be more like symptomatic when you auscultate the patient?
Oh, of course you're going to have crackles
Like symptoms.
on auscultation. And mostly bronchi when you only have pneumonia and not effusions associated with it. Okay? You need a lot of exposure to imaging to be able to see that. Okay? So again, you basically have a patient with pleural effusion on an x-ray. You are not sure the size of it. You do first lateral decubitus by an exam, and you can confirm with ultrasound of the chest the amount of it. So again, remember, you have a small effusion. Imagine putting a drop of water in your lung or my lung that is dry at this time. You can have so much shortness of breath with a small drop, okay? But if you start having one drop every single day and you fill it up, some patients that have malignancies, they have a large effusion and no symptom. Whenever you see an x-ray that has a large effusion and the patient is reading the newspaper, you have to think, I've seen it a lot, think cancer until proven otherwise. That's not a good prognosis. Because if I drop a drop of water in your lung right now, you're gonna be short of breath. But unfortunately, small effusions cannot be tapped because of the risk of pneumothorax, okay? So from moderate, if you have a moderate pleural effusion and the patient is symptomatic and hypoxic, that's a consideration. Of course, you're gonna treat the underlying condition all the time, but another adjuvant treatment that you can do is thoracentesis. Now, large effusions with or without symptoms have to have a thoracentesis. Even if you don't have a symptom. Why? Because think about it, this hemithorax is full of fluid, it's pushing my mediastinum to the other side, and it's gonna compromise preload and cardiac output. That's the reason why we do it, even if the patient is not symptomatic. But at the same time, we do a diagnostic test on it.
So if it's moderate, non-symptomatic?
If the patient has moderate pleural effusion and has no symptoms, or mild symptoms, treat the underlying condition first. Thoracentesis is a very aggressive procedure that the patient can bleed and convert into a hemothorax, and also pneumothoraxes. And the patient, and then ends with a chest tube. Now, you do a thoracentesis one time, you do a thoracentesis 2 times, and the patient continues to come back with pleural effusion. Do you tap the 3rd time?
No.
No.
You do a shunt.
You have to have a pigtail, which is no more than a drainage, a catheter, which is called, it's not actually called pigtail, it's called Pleurex catheter.
I had a patient like that and they never did that. It was constantly the therapy.
Pleurex catheter, okay? And you teach the patient how to drain that at home, or you bring home health with them. That if the patient is able to comply and the patient is able to follow commands and all that, right? Otherwise, the patient stays in the hospital with the pigtail or the chest tube, all right? Another way to do this, even more if you have cancer, okay? You can go inside and do what's called, I forgot the name. Basically, it's an invasive procedure that you either do a mechanical scraping of the pleura, okay, or you inject either talc, pleurodesis. You inject talc, or you inject erythromycin, which is it's basically a chemical irritation to the pleura to be able to have the pleural, parietal, and visceral to seal and not allow any more fluid to go into the interface, okay? So as you could imagine, this is a very inflammatory process that can produce more effusions. So what I have seen, the majority of them, they seal very properly. That's more than 90%, but I've also seen 10% of patients that go into ARDS and more effusions, because again, don't forget that it's an inflammatory process. What we're doing right now in patients that have no contraindications for TPA, instead of injecting erythromycin, we inject TPA into the pleural space. Very small amount. TPA, remove it, yes. Okay? Any question? This is no more than the amount of pathogens that, as you know, in infectious processes, the most common are strep pneumonia, Moraxella catarrhalis, and influenza. So, again, you basically look for an ultrasonography, and again, remember, lateral decubitus, as you can see, is right there, okay? So in the ultrasonography, what the tech is looking for is the more than 10 millimeters thickness of the fluid, and if that is present, it's more than moderate to large, right? So if that is present, you have to basically go through the history of the patient to see if the patient has a possibility of a transudate or an exudate. So you go already with your mindset, like we already have for this patient, most likely it's an exudate, but the results unfortunately were completely opposite. So if the patient has, for example, history of heart failure, and the effusions are bilateral and symmetric, what are you expecting? CHF, right? And if so, if the patient has moderate with no symptoms, you basically treat the underlying condition. Diuretics, ACE inhibitors, right? The same treatment for CHF. If the patient has moderate with symptoms or large, you do thoracentesis, and this is basically the analysis of the fluid as we already did, okay? Now this is not the only thing that you do. You can even analyze gram stain, many cultures. You could do cytology and pathology reports. You could see cells of cancer in the fluid. You can also do, for example, glucose level. let's talk about glucose. If you have cancer, for example, would you have a large consumption of glucose? Bacterial infections versus viral?
Yes.
Okay, the same as meningitis. You could also do markers of TB in the pleural fluid. So you could do AFB right there. You can also think that, where would you think that rheumatoid arthritis and lupus will be in? Transudate or exudate? Rheumatoid arthritis and lupus, where are you thinking that they will be listed at? Transudate or exudate?
Actually, it's just like.
Okay, I understand that lupus, again, remember that medicine is not a chain of commands. What came first? Okay? So I understand that lupus can give you lupus nephritis and proteinuria, and that's transudate, but the major problem is an autoimmune condition, which is an inflammatory process. So that's an exudate. Okay? You could do D-dimers, so you could do ANA, you could do RF, you could do all the markers of the autoimmune diseases in thoracentesis. Alright? You could do D-dimer, you could do a lot of things. You could do amylase, you could do lipase, if you're thinking about pancreatitis. Okay? I understand that you would do it in serum as well, but you could do it in thoracentesis to match. Okay? You could actually measure the amount of neutrophils and lymphocytes or eosinophils. Having a lot of eosinophils in thoracentesis is the same as plasma, parasites, allergic conditions, because a lot of patients tend to have, for example, allergic pneumonitis or alveolitis, or cancer can give you also a lot of eosinophils in thoracentesis. Okay? Russian here. So comparing, for example, remember that glucose is highly consumed in patients that have any type of infectious process or major inflammatory process. So in exudates, patients tend to have low glucose as well. So you could also look at that, even though it's not reliable as the calculation that we just finished.
Wait, why is it? Because it's eating up the glucose, so the sugar is low.
Yeah, the metabolism of bacteria is
using it.
Yeah, it's using it more than virus. Cancer more than
For energy and
heart disease.
Okay.
All right. Amylase, as you know, that amylase is present at the level of the entire GI tract, and not only at the level of the pancreas. So if you have esophageal cancer or rupture, or if you have liver problems or pancreatic problems, can give you high amylase. So you can measure a lot of stuff there. We talked about LDH, and you can even do tumor markers in pleural fluid. Okay, because how valuable thoracentesis is. Even though we basically use it the most, pulmonary, no, we do everything. But if thoracentesis is ordered by a hospitalist or any other practitioner, they basically only concentrate on proteins, LDH, and that's it, to be able to do the calculation. Okay? So, as you could see here, for example, looking at the color gives you an idea as well. If it's a chylothorax, if it's an empyema. So it's not only the pressure that the fluid comes out, but it's also the quality of the fluid, meaning that is it bloody? It could be traumatic, but if it's traumatic, the amount of RBC wouldn't bypass more than 5%. Okay, and it will be mostly serous sanguinous versus franky blood, and more than 5% of erythrocytes if it's an actual hemothorax. Okay, and you could actually measure the amount of hematocrit that fluid has. If it's cloudy, it could be, for example, a chylothorax, like milky type, and that you have to think about lipidemia or patients have cancer. If it's turbid and has a fetid odor, for example, is an empyema, and mostly bacterial infections. So looking at the color also will tell you, or give you a good idea. And so what will be for the exam? The major content